Ian, what about screening? What's recommended by the U.S. Preventive Health Task Force? What are we supposed to be doing? Screening? If we have, generalist, community physician, family medicine physician listening, what should they be doing?
Well, the recommendations are that every person aged 15 to 65 be tested for HIV at least once in their life. It doesn't mean you shouldn't be testing younger individuals who may be sexually active. It doesn't mean you shouldn't be testing older individuals, older than 65, who are sexually active. Maybe they're divorced or their partners have died. They have new sexual partners. So everybody should be tested at least once. Pregnant women should be tested during their pregnancy at least once. And then individuals should be tested again depending upon their risk group. So for men who have sex with men, for individuals with a sexually transmitted illness, for individuals who are injecting drugs, those individuals should be tested at least on an annual basis, if not more often. Pregnant women who may come in contact with HIV because of sexual risk should be tested during their third trimester, and if they've been tested earlier, because women who acquire acute HIV infection during their pregnancy are at more likely risk of transmitting their infection to their either the fetus or the newborn. So those are the general recommendations.
And Julia, you've really thought about this. I mean, in part, kind of identifying people for pre-exposure prophylaxis, but really it's about identifying people that are at high risk and probably should be tested more frequently. So we can use this as a way to start talking about PrEP, but talk a little bit about, in a general practice or in any kind of practice, how do we find these high-risk people? We're all busy. We're supposed to be doing 15 things on a list. What do we do?
Yeah, I think it's a challenge, and it's one that the USPSTF actually identified in their systematic review when they put out their PrEP recommendations. They said there's really a lack of effective HIV risk assessment tools out there. Right. And there are some that exist based on CDC criteria for what constitutes a good candidate for PrEP, which is similar to the USPSTF criteria for HIV screening. But those tools have some limitations. Mm-hmm. For one, they're really developed for men who have sex with men for the most part. So a provider already has to know that a patient is in that risk group before they're going to use one of these tools. They're hard to use in a busy clinical practice, and they also underestimate HIV risk in Black men who have sex with men in particular because they're based on individual level behaviors, but HIV risk for that community is much more driven by network factors.
Network factors and who you're exposed to. Yeah, I think the one thing is just first talk about sex, right? Allison, you have to deal with adolescents. Probably talk about sex a lot.
Well, you'd be surprised. So I happen to talk about sex a lot in my practice, but there's actually studies to show the average provider, even the adolescent provider, spends 30 seconds talking to adolescents about sex, right? And so that's adolescents where we assume we're going to talk about sex. Imagine what's happening in the over 55, yeah, where we as physicians may be uncomfortable and we may not even bring that up. And the patient's uncomfortable. So we have a whole problem talking about sex. And so if we can't talk about it, how are we going to risk stratify and decide who should be tested or not tested, et cetera, and offer PrEP, right?
Yeah. And the other thing that kind of bothers me now that I'm 61 is why did they stop testing people at 64 or 65? That doesn't make any sense to me. Does it? Ian.
Well, I'm older than you. And it was the point I was making before. I think we have to ask people what are the behaviors they are engaging in. And I worry more, Allison, as you point out, that older folks are less likely to be asked these questions because assumptions are being made. The assumption is, oh, they're married or they're too old to have sex or whatever the assumption is. And you're not going to ask the questions. It's not hard. You can preface the questions by saying, I ask all of my patients these questions. Right. So that already means I'm just not asking you because I'm worried about you. I ask all my patients these questions. And, are you in a sexual relationship? Is it with a man? Is it with a woman? Is it with men and women? It's not hard to ask these questions in 30 seconds. really, and get a lot of information. And sometimes the conversation could go longer. But if you are taking care of somebody who you've been taking care of for a while and you have a trusting relationship with the patient, it's not hard to ask these questions.
I think the most important thing is to routinize it, right? To make it a part of every single interaction you have with a patient. So then even if you are uncomfortable asking those questions, over time you become comfortable. If it's just routine, you just do it every single time, you do become more comfortable with these things.
Yeah, and I think, that testing for HIV, I mean, if you had a disease where the therapy could prolong your life for 30 years, would you want that test? I think so, right? I mean, that makes sense, right?